Welcome to today's webinar. Just before we get started, I wanted to make a quick note. If you have signed in today under somebody else's link and your name is not your name on your screen, if you would do us a favor and go ahead and update that so we can keep track of everyone who's present, that would be helpful. By way of introduction, my name is Stacy Villano, and I work for the Global Rural Nursing Exchange Network. Our mission is to connect individuals who have a passion for improving rural health in communities worldwide. This includes nurses, educators, students, researchers, and anyone who is serving rural communities. We do a lot of work with partners like USD, and that helps us expand our knowledge base and our education and helps us connect rural communities worldwide so they can get a better understanding of how they can continue to improve in their local area. So we are very grateful for this partnership, and we are working with USD in this specific role to help encourage students at USD and beyond to consider rural for their future careers and to give educators worldwide this idea of things that they might be able to implement in their local areas to help encourage that career path as well. Just before we get started, some brief housekeeping. I know we just asked you to make sure that your name was updated, but keep your microphone muted. It should automatically be so. This just helps prevent feedback during the presentation. Of course, if you have a question during the Q&A portion, we invite you to unmute and ask your question at that time. Just make sure you turn that back off once you're finished. Keep your video on continuously through the entire course of the presentation, please. And given the nature of our discussions today, we do ask that you maintain confidentiality at all times. Sorry, I'm letting people in as I'm speaking to you. If my mouse looks like it's jumping around. If you have a question during the session and it's not particularly a Q&A, just drop it in chat or in the Q&A panel. We'll get that for you. We don't want you to forget it. All feedback is great. We really encourage contributions to the discussion, sharing your knowledge, asking questions. So feel free to do that at any time, even if we're not collecting Q&A at that specific moment. Keep in mind that in order to support the growth of the ECHO project, Project ECHO does collect participation data for tele-ECHO programs. With that, I'm going to go ahead and bring that to our wonderful presenter today, Dawn Warren.
Hi, everybody. As usual, it's wonderful to see so many different people that have joined us today. And a lot of students, which is excellent. It's a great way to learn about what's happening in rural healthcare. So I have been working with USD for a long time, about 30 years, and on this grant for the last 3 years. And so this is kind of the end of our ECHO series this month. We just have a couple more. The main ECHO focus has been just related to rural healthcare in general. And the focus today is on housing, transportation, and lifestyle barriers, kind of just barriers in general, not only for students, but for just patients and et cetera, just some of the challenges we have in rural healthcare. Okay, next slide, please. So a little bit about our grant. I know many of you have heard this many times, so I'll kind of do the speed version. But we obtained a HRSA grant. It was a 3-year grant, and we obtained $1 million for that. And the grant just ended at the end of September. So these ECHO sessions this semester are the end of the dissemination process. And the grant had multiple pieces and parts to it, but probably one of the most exciting parts that these students will talk about today is the experiences that they had in small rural hospitals across the state, in which they did a 132-hour clinical immersion for most over about a 3-week time frame. And we did have some who did it over the summer and was spread out, but in general, it's a 3-week time frame. Okay, next slide. So we are located in the United States of America. For those of you who may be listening from other countries down the road. And we are located kind of right in the Midwest there in South Dakota. And this is just a map of the state of South Dakota. This gives you an idea, even though there are even more than this. We've had over 100 students do this HRSA grant, and they have been spread out all over the state. Um, the one area that you can see kind of up top here that really hasn't had much, if at all, is a very, very frontier area. But the whole state is very rural and does present quite a bit of challenges. And so we'll be talking about some of those today. Okay, next slide. So our objectives today, there's two parts always, and the one is to hear from the students who completed the entire clinical immersion, where they talk about their community and some of the key lessons that they learned. And then the second is to focus in on a specific topic. So again, today we're talking about housing, transportation, and lifestyle barriers in rural South Dakota and their impact on healthcare. And we have a great speaker with us today that I'm excited to introduce you to here towards the end. And we're also blessed that one of our students today is specifically going to do her presentation just on transportation issues in one of the communities in South Dakota. Okay, next slide. I'm not sure if Paige is with us yet. I don't think, Paige, are you with us yet? Okay.
She just got done with an exam. She'll be there shortly.
Okay, no problem. We're going to go ahead and go to the next student. So we're going to skip past Paige and we're going to start with Caden. So this is a test day. So as you know, tests are important. So one of the students, Paige, will bring her up at the end. So we're going to start with Caden. Caden completed her clinical immersion for the HRSA grant at Freeman Regional Health Services, which is Navarro Hospital, and that was located in Freeman, South Dakota. So I am going to turn it over to you, Caden.
All righty. Yeah, as Don said, I finished my HRSA in Freeman. So these are just two pictures. The one on the left is just kind of showing an example of an inpatient room. And on the right is actually our little tiny emergency department. So as you can see, it's like technically considered a 3-bed ED, but the middle bed is technically just like a chair. But yeah, you can go to the next slide. Thanks. Okay, so to start with our community healthcare barriers, I found that the biggest barrier for a lot of people, at least especially during this time of the year in the fall, was that it is harvest season. And so a lot of the people that came in were farmers. And obviously, farmers don't want to be in the hospital. Farmers want to be out farming their land, especially during harvest season. So I feel like the biggest thing for them was just being super anxious about getting back on the farm, and they might not have anybody to be harvesting their land for them right now. So that was really hard for a lot of the patients there. Hospital overview, I kind of mentioned it. We have that 3-bed ER, and then other than that, we just have 6 inpatient beds. We have PT in hospital, we have OT in hospital, we have X-ray, and we have like our labs. But other than that, we don't have a ton of resources. And a lot of people would have to be transferred out to go to Sioux Falls for a lot of different things, which could also be a healthcare barrier. Memorable story might not be super memorable for like your typical sense that people might think, but for me, it was pretty memorable. For just a little background information, I did my internship last summer in the ER in Sioux Falls. So I never spent a ton of time with any like singular patient. It was always people coming in and out. And so I guess my memorable story is just that my very first day on the floor at Freeman, I got to be with a patient who was his first day coming back on the floor, and he was in a swing bed. So he was just like in a rehab type room. And so his first day was my first day, like I said, and I actually got to see him through his whole care. So like it was really special because his last day was the day after my last day. So he got to go home the day after I finished my last shift. So it was just really special for me to be able to see him come and kind of be in the position he was in and then be able to get healthy and go through that PT and the OT and eventually get to go home. So that was just something special for me, I guess, not normally getting to see patients like that a lot of the time. Key lessons learned. I really honestly didn't think I would like being in a rural facility as much as I did. And that also might have a lot to do with the people that I worked with, because I think we all know coworkers can make a big difference in situations like any situation, any job. But the people I worked with are really just phenomenal, and I am really going to miss working with every single one of them. Unfortunately, I am already committed to working somewhere else for 3 years after I graduate here in December, but um, definitely somewhere I would consider going back and working after my 3 years are up. I really enjoyed working in a rural facility.
Wonderful. Thank you, Kaden.
Yes,
You brought up a couple key points. Number one is just the relationship piece, which is a lot of the reason that people go into nursing. And I've been an ER nurse too, and your relationships are very, very short there. So
yeah,
having the luxury of really getting to see a person's entire state is a blessing and something that you would get to enjoy when and eventually hopefully end up in rural care. So
yes,
and then I was going to bring up, farmers in general, just farmers. Um, that is a huge problem in our state, as you know. Not only harvest season's the worst, but just year round, because they are not good about going in when things start. They wait and they wait and wait because don't want to leave the farm, and then a lot of times it's too late or they're really sick. So I'm really glad you brought that up. Okay, any questions for Caden? Otherwise, we'll save till the end. So if you have something else you want to jot down, that's perfectly fine. Okay, thank you, Caden. I think we'll go ahead and move on. All right, Miss Hannah Parliament. Hannah completed her HRSA clinical immersion at Pioneer Memorial Hospital in Viborg, South Dakota. So Hannah, I will turn it over to you.
Perfect, thank you. Yes, like Dr. Warren said, I was in Viborg at Pioneer Memorial Hospital. That's kind of that's the entrance part of it. You can go to the next slide. There's quite a few pictures. So the picture on the left, that's the emergency department. It's 2 beds, very small. And then on the right, that is just one of the patient rooms. A lot of the rooms there have 2 beds. So there's the potential to share rooms. However, when I was there, at least we didn't have to buddy up in rooms at all. But next slide. So my community healthcare challenge that I saw was kind of related more towards the transportation side of things, and specifically for the residents in the long-term care. So at Pioneer Memorial Hospital, there's a long-term care facility connected to it. So the transportation from the long-term care facility to, say, like the emergency department wasn't the problem. The problem that I saw was when it came to those residents that may have been in at a different facility, and then once they've came back to the long-term care and they need to go back for like follow-ups or other kind of appointments that are at facilities that are farther away. I had a few cases in particular where like they were post-op and they had gotten discharged, but then there was maybe a complication or and they just didn't have the resources to be able to go up to, say, Sioux Falls, for example, for those follow-up cares. So then it ended in them being admitted to the ED and then having to transport them out via ambulance, when that all kind of could have been prevented if there was better access to those transportation services. Kind of going off of it, they are doing things to try and help this. They have the ROCS bus, which is the Rural Office of Community Services, which this provides cheap transportation. I know a few other rural communities have this too. However, there's also barriers to that. That typically doesn't go long distances, like all the way up to Sioux Falls. And it does cost money, although it is at they say an affordable rate. However, That can still be a barrier for some. And then they only operate in specific hours. So depending on when your appointment is and stuff, they may or may not be able to accommodate to that. And then again, not everyone has the family or friends to be able to transport them to those kind of appointments. The hospital overview kind of mentioned some of it already, but they provide hospital acute medical cares. They have 8 rooms, but technically 12 beds with some of those buddying up. They care for swing bed patients, observation beds, and then they do have 1 respite care suite. They have 1 surgery room, which they do colonoscopies once a month, and then that 2-bed emergency room. Other services they have are lab and therapies like PT, OT, and speech. They also do outpatient therapies like IV therapy and blood transfusions. They can do stress testing, cardiac rehab, radiology, like X-ray, CT, and then they have a DEXA scan. And then touching on those long-term care facilities, they have a 51-bed nursing home. They have an Alzheimer's and dementia unit. They have assisted living apartments and also independent living apartments. And all of those long-term care facilities are connected to the main hospital. And then they also have some other services like mobile services such as mammograms, MRI, and ultrasound that come usually once a month. And then they also do outpatient specialties. For my memorable story, this was one of my last shifts when I was on my immersion, but I had a 17-year-old peds patient come in to the ED. She had complaints of 10 out of 10 abdominal pain, nausea, vomiting, and constipation. She couldn't really think of anything specific that kind of initiated these symptoms. So that night when she came in, they did an enema and had no results from that, and also gave pain meds, which provided temporary relief while she was at the hospital. And then initially no labs or imaging was done for her, which is I found interesting because typically any ED patient, that's the first thing you do is you get your labs. So that was initially, and then she was discharged home that night. She was given another enema to do at home if the symptoms continued. So then the next day, this was the day that I was actually there. She came again to the ED with those same symptoms, increasing intensity of pain. And then she did that the home enema, and again, no results from that. This time the labs were drawn, and then there was an X-ray. The X-ray was abnormal, so then they continued imaging where they did a CT scan. And the CT scan revealed a 9 by 4 inch complex abdominal mass in her left upper quadrant. And I think the most memorable part of it for me was just being able to see how the provider interacted with not only her, but also her family during this time, because when anyone hears that they have a large abdominal mass, of course, their first thought is, oh, is it cancerous? So of course that was one of the big questions. And just seeing how professional the provider was, just saying that at this point, we don't have the resources here to do that additional screening to determine that. So we'll have to transfer you to Sioux Falls, where they will do more testing and imaging and stuff. So yeah, I think that was kind of one of the most memorable patients I had. And then for my key lessons that I learned, the main one was just how adaptable you have to be working at a critical access hospital. You're a nurse, you're playing the ER nurse, you're playing the med surg nurse, critical care nurse at times. You're being that case manager. You're providing those like respiratory, you don't have respiratory therapists, so you're doing those. So just kind of being adaptable and being able to play all roles. And then another one was just the importance of a positive culture. In Viborg, that was one of the most family-like cultures that I'd ever seen in the workplace. And it kind of going from being in the hospital setting to seeing this, everyone knew everyone within the hospital. And also with the patients, like a lot of the patients came in, like they knew that it was part of their community, kind of where everyone knows everyone. And I really think that kind of shifted the way communication was within staff members, but also the way they cared for the patients. Like they truly, they knew these patients, so it was they were truly going to do anything they could to help them. So, yeah.
Wonderful, Hannah. I was writing down multiple things, but your example of the compassion and the empathy that they showed when that girl obviously found out she had that mass and how scary that would be at any age, but especially for a 17, you said, right? Yeah, that would be terrifying. So the difference that can a compassionate caregiver can make when giving that kind of news is huge. So I'm glad you got to witness that. And then just the setting, the culture, I think is huge too. I worked in small rural hospitals as a new grad, and the culture, again, it was like none other that I've ever seen. And I haven't really seen that as much in great big hospitals. So another advantage to being in a small rural setting. Okay, we're going to keep moving along and come back later if people have more questions. So keep track of your questions. Okay, I would like to introduce now Emily, who completed her clinical immersion preceptorship for this grant at the Douglas County Memorial Hospital in Armour, South Dakota. So Emily, it's all yours.
Hi everyone. I'm Emily and I was in Armour, South Dakota, which is population a little less than 700 for reference. You can go to the next slide. So this is the entrance to the ER. And then yeah, you can go to the next slide, sorry. So for my community health barrier, every single patient that I saw either in the ED or admitted to the hospital had to rely on someone to get them there. They all either needed somebody to help them like arrive to the ED, transport them to like follow-up appointments, and like with just their care in general. And so I think that's a big barrier, is that all of the patients that I saw had to rely on somebody else to get their care, and then also like to make sure they're taking their meds and that they're actually taking care of themselves, which can be hard because I know some of my patients, it's not like, it might not be their spouse, but it could be like their grandson who they need to call to come help them because they can't do things for themselves. Hospital overview, like I said, the population is a little less than 700. And hospital setup, we had 12 swing/acute beds, and then we had 2 beds in the ED, which is pictured right there. There's just a bed next to it. And then a couple ED rooms out in the hallway, and then 2 outpatient rooms, like down on the other side of the hospital. And then there's also an LDRP room, but they don't deliver babies, so they don't really use that for that anymore. And then there's a clinic and an assisted living attached to the hospital as well. And then for like staffing, every shift they have 2 nurses and 1 tech. For like the hospital/ED part. A memorable story, one shift, so I had all night shifts. And so they got a call at 5:30 p.m. Of a bus versus semi truck. So my nurse just texted me to like warn me that it was gonna be chaotic once I got there, because we did report at 6:45. So I was getting there, and right when I was getting there is when they were transporting everybody out. So they had 3 kids on the bus, so all of them had to be transferred to Sioux Falls. 2 of them went by helicopter and 1 went by ambulance. And then we also had the 2 drivers, which both of them were fine and they were just in the ED for a little bit. But that was really interesting to see, because when I got there, I had to park on some weird side street, and all of the clinic nurses and anybody else in the community like came back to the hospital to help. And so it's really cool to see that many people help, and then also just like their process, because one of the just like staff nurses, she had to be the one to coordinate with the flight team and everything about how to like get them out. So I thought that was really interesting that she had to take on that role. And they have 1 helicopter pad, and then the other one had to land in the church parking lot across the street. And then I also think it's interesting, one of the nurses had to go with one of the patients that went by ambulance to Sioux Falls. She had to be with that patient to make sure everything was okay there. So it was just really cool to see everybody work together. And then they did their debrief after that, and so I kind of got to hear a little bit of that. And then my key lessons learned, rural nurses have a lot of autonomy, which can be good or bad depending on what you like. And my nurse, as well as the other ones, were really good at anticipating what the provider would want. They know their provider so well that they can anticipate the orders they want, the specific med they're going to want, which I think is really awesome. And like I've never talked to a doctor at a big hospital, but I got to know a couple of the providers on like we talked about like where they went to med school, where they grew up, stuff like that, which I think is cool that you actually get to build that relationship. And even just with all of the nurses, they were so welcoming and so nice. And I got to know them really well in the hours at 3 a.m. You really you really get to talk to your coworkers a lot, so that was cool. And then a lot of the nurses and techs are also like volunteer um like EMTs in the community, so that was cool too because a lot of them when they're not working are on call and they go and help. Like I know for the bus crash, one of the techs that I always worked with, she responded to that call, which I just think is interesting because it also gives you that little bit of more insight. And then she also knows exactly what the nurses and the providers, what information they need to know.
Excellent, Emily. Although nobody wants to see an accident like that or hear about an accident like that, I'm so glad you were able to see because what a great learning experience. Just to, like you said, how everyone comes together in a small community and the whole community knows when something happens. And so anyone who can and has the ability to help, well, typically it's like you all come and they all do. So,
And all of them are home and well. So,
oh, that's even better. That's awesome. So glad for the update. Yeah. Anytime you hear bus stuff, it's like, oh my goodness, this could be bad, right? Yeah, so excellent. I'm glad you brought that up. I also wrote down autonomy and relationships. So we're hearing relationships as a theme over and over in these small rural hospitals, which is excellent. And yes, a ton of autonomy. So you really get to have a lot of independence, but still have people available if you need them. So it's kind of a cool way of being a nurse. So, okay, well, thank you. I think we will go ahead and move on. I believe Paige is back now. So we're going to give Stacy a second to go back up to Paige's slide. And then I am going to turn it over. Let's see. There we go. So Paige completed her clinical immersion at the Wagner Community Memorial Hospital, which is also part of Avera, and that was in Wagner, South Dakota. So Paige, it's all yours.
Right. So yeah, I completed my immersion in Wagner. Wagner has about a population of like 1,400, so kind of small. But yeah, the community of Wagner is it's a nice little community. There are a few barriers that community members do face within the community, such as like transportation. Typically, you'd see like people coming in or family members bringing them in that didn't live with them, or like um, or you would see uh, people like not being able to afford to take to be transported by like the ambulance um, and whatnot. So that was kind of new to me, seeing that, and they would just come in later, typically. And then within the community, there was someone else had mentioned it in their presentation, the Rocks transport, public transport. I think Hannah did, but they also had that service for people to be able to use. And there is kind of some substandard housing within Wagner. So I think a lot of the population of Wagner is kind of lower income. So that kind of goes hand in hand and whatnot. So the hospital, Wagner Community Memorial Hospital, it is a 15-bed critical access hospital. It has med-surg area, two ER beds or rooms, I guess, and then one treatment room, and then they have like one room designated for like pregnant people or pregnant women. So they have those, and then they also have like 24-hour on-call lab and radiology. So if we needed them, I worked night shift, so typically like they would be sleeping in like the back if we needed them, we would just call them. So yeah, and then we have like outreach services as well. So there were a few times where we had used like the telehealth or like an iPad for getting for a call for a provider and stuff with some patients. So that was cool seeing that. Um, and then a part of or adjacent to the hospital is like the Wagner Community Clinic. So it makes it a little easier for like patients, to come in and get like their clinic appointments and then also get like testing for or be treated for anything if they need to be like admitted or whatnot. So Wagner also for the radiology, they have they have just a CT. And so if they like needed like an MRI or anything, they would have to go and get transported to a bigger hospital. My memorable story. So there was this patient who it was this like peds patient that came in. She had accidentally gotten like a Tide Pod, like the detergent in her eye. And the little girl's grandmother brought her in, but it was I just remember the key thing that I remembered with that was like, you could do as much as possible. And we tried flushing her eye, it requires like I think either 10 to 20 minutes of like continuous flushing for like protocols for getting like detergents in your eye. But for her, we like really tried our best. I think we probably got maybe 5 minutes, if that, of being able to flush her eyes out continuously. And it was just a struggle because not only was she was just fighting against us and, all involved. So, and she was all obviously like agitated and crying and whatnot. So I think just doing your best, you're not going to get, everything's not going to be successful, but doing your best in order to prevent, things down the line. I think what we did with her was we just sent her grandmother home with like a flush with what we were able to do because eventually the grandmother was getting upset with us about, just we tried like 3 different ways of doing this and just none of them worked. And so the grandmother was getting frustrated and she was just kind of had it. And although like we knew like the importance of, this needs to be done, and trying to like tell that to the guardian, just kind of like seeing like, if the patient's guardian says like, is enough, you just got to kind of deal with it and send them home with, what, we just sent them home with like flush, like saline flush bottle. So just doing what you can is really what I saw and learned from that. Not everything you're going to be able to do. But yeah, with the Wagner Hospital, the staff, like everyone else kind of said, like the staff are, really great. It's a tight-knit community. Everyone's there to help each other. And, even if you're not like asking for help, people are still going to come in and help you with your patients. So just like having that kind of sense of support and they're very close knit. So having all that kind of relationships bouncing off of everybody else is really nice.
All right, great job, Paige. Yeah, those good old Tide Pods. Boy, you hear stories about those, don't you?
Yeah.
Yeah,
At least she
classic.
didn't eat them.
What's that?
At least she didn't eat it.
Well, that's true, right?
Yeah.
Classic example. My first rural job in a small rural hospital, we had a person who came in who got fingernail glue in her eye.
Mm.
Yeah. So yeah, sometimes there's only so much you can do. Flush, 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 and hope for the best. And if not, they usually have to go to a see an eye doctor. But okay, well, good job with that, Paige. So if you have questions, hang on to those. Otherwise, we're going to continue on. So Pamela, we'll slip back. There we go. We're going to now turn it over to Pamela. Pamela completed a couple shifts at the hospital that she was at, but wasn't able to do the entire immersion. So what she is going to talk about today, and she's done a great job on this, is she spent some time looking into transportation challenges and their impact on healthcare. And she's going to kind of focus on one community, but as a great example for a lot of the things that we see across the state. So Pamela, I'll turn it over to you.
Hi, everyone. Like Professor Warren said, my name is Pamela Zuluaga, and today I'll be talking about something that doesn't always get enough attention when we think about healthcare transportation. In a small rural community like Gregory, South Dakota, transportation isn't just about getting from point A to point B, and it can truly determine whether people get the care they need when they need it. So Gregory is a close-knit town with around 1,300 residents. They have a Vera Gregory Hospital, which is a critical access point providing emergency care, basic lab work, and some out-of-patient services. But when you need to see a specialist like a cardiologist, oncologist, or a neurologist, those services are often more than 100 miles away in cities like Sioux Falls or Rapid City. And for many people there, that distance combined with limited public transportation can turn a routine checkup into a major challenge. So some transportation challenges that I found was, well, first, distance and geography. The first issue is simple. They're far from major medical centers. A specialist appointment might mean a 2 to 3 hour drive each way. And for older adults, those with chronic illnesses or anyone who doesn't drive, that is a serious barrier. Limited public transport. Gregory does have a community transit service, like they mentioned before, the Rocks. Um, it helps seniors and Medicaid patients to get to appointments, but it runs mostly on weekdays during business hours and required advanced scheduling. That means if someone wakes up sick on a Saturday or need to get to an urgent care or a follow-up appointment, there might not be a ride available. Another one is weather conditions. We all know that South Dakota winters are no joke. Snowstorms, icy roads, and high winds can make it dangerous or impossible to travel. Also, when highways close or visibility drops, even emergency vehicles have trouble getting through, and that can delay care or access to hospitals altogether. EMS and emergency delays, emergency medical services in rural areas are stretched thin. Ambulances often cover large territories, and it can take 20 to 40 minutes or even longer to reach someone in distress. And if a patient needs to be flown to Sioux Falls or Yankton or any other bigger hospital, but weather can delay helicopter transport too. Financial barriers, gas prices, vehicle maintenance, and missed work hours all add up for families living paycheck to paycheck. Just getting to the doctor becomes a financial decision, and many choose to wait until it's an emergency. So how do these transportation barriers actually affect health outcomes in Gregory and pretty much in any rural community? Missed appointments when people can't find a ride on the roads are bad. They skip routine visits, things like checkup, follow-ups, lab works, and over time, this leads to poor management of chronic disease like diabetes, hypertension, and COPD. Also, delayed diagnosis. If someone has a new symptom, for example, chest pain or a suspicious lump, they might wait weeks or months before they are able to travel for a diagnostic test. And this can turn a treatable condition into something much more serious. Increased emergency visits when routine care is inaccessible. people end up using emergency rooms for problems that could have been managed earlier or at a lower level of care. That raises healthcare costs for both the patients and the system, and worse health outcomes. Rural residents already face higher rates of heart disease, stroke, and certain cancers, and the lack of transportation only makes that gap wider. For some, it's not about refusing care, it's simply about not being able to get there. So, yeah, in conclusion, these challenges in Gregory and many rural places may seem like a logistical issue, but they're truly a public health issue. When people can't get to care, health declines, cost rises, and preventable conditions turn into emergencies.
Excellent, Pamela. I remember when I was reading through what you were going to talk about, I really thought you really said it's not about choosing to miss or not get treated a lot of times. It's that they can't get there. And that is a very substantial problem in our state. So I think you did an excellent job of summarizing the transportation challenges in rural communities. So thank you. Okay, we're going to move on now, and I'm going to turn it over to our expert subject matter for today, which is Teresa. And Teresa, I don't want to mess up your last name, so I'll let you say that part.
That's okay.
But Teresa is from Huron, and I've met her with a couple of the things with some of our grants, and she just does a fantastic job and was willing to speak a little bit today about housing, transportation, and lifestyle barriers. So I will turn it over to you, Teresa.
Sounds great. Thank you. Let me get my, let's see here. Trying to share my screen. I'm not seeing my slides.
While you're looking, while she's trying to find that.
I had them up. I'm not sure why they're not showing up.
Do you have your PowerPoint down at the bottom?
Yep.
Okay.
Let me.
And did you hit share and nothing's?
Yeah. It's open, but when let me try it again.
Okay. If you want, you could, if you want to email it to me, would that work real quick? And then I can try and pull it up for you and let you start.
Sure.
Okay.
That's really weird. Why is it not?
Yeah, I don't know.
It's not showing up as a share item, right? On my.
Yeah, no, we just see you.
Yeah. That's weird.
And if you want, you could just talk about it too.
Yeah,
it's totally up to you.
I sure can.
She's a registered nurse and we adapt very well, don't we?
That's right. We got to do it too. So we are also here. Thank you first and foremost for having me today. I apologize why that's not coming up. But we are a critical access hospital also. I have to say I've joined a couple of these sessions and I just keep nodding my head on so much of what all of you have said in these experiences that you've had at these rural settings. So us as Huron Regional Medical Center, we're a little bit larger. Our population of Huron is about 12,000. We serve close 37,000 probably in the surrounding areas. So we're a little bit larger than some of your communities. Our average daily census is probably 11 to 12 in the med-surg area. And then we have a lot of ancillary departments also, as many of yours did. We are probably the fourth largest in Beadle County as an employer. So we have probably about 400 staff members here in all. So we have our main hospital. We also have a 2-story clinic, which houses internal medicine, general surgery, orthopedic surgery, nurse practitioners and family medicine, pediatrician, and a podiatrist that is new to our community. So some really great access to care that, again, some of the smaller areas don't. We also have another separate clinic that houses a general surgeon, family practice, and a PA. And then we have outpatient, it's pro rehab. It is a separate entity for outpatient physical therapy and occupational therapy. So we have a lot of options for our community there. In addition to that, we do have an obstetric unit, which is pretty rare for a critical access hospital. We deliver probably between 325 right in there a year for babies. So we have the nursery, a pediatrician, as I mentioned, on board too. Our emergency room is a 9-bed, and it also has right off of it an outpatient of 3 rooms for those IV therapies, maybe some chemo medication if I've need something for nausea or those type of things that they can come in for. The staff support each other if there's busyness going on, and that also in those areas purposefully. We also have home health and hospice. I don't know if any of you have experienced that or worked with that at all. They go to the home, support our families and so forth once they're discharged or in that hospice care. And then we have a separate dialysis unit also. 12 chairs Monday through Friday right now. Well, 3 days a week. At times it's 6 days a week, depending on our need. There was a huge waiting area, our waiting list and that has become a high need, and especially, I think all over, not just in rural medicine, obviously. We do have, as I mentioned, 2 general surgeons, and then we also have 2 orthopedic surgeons. So those patients are up in the hospital, keeping our therapy departments busy. We do have a robotic for our surgeons, so we're trying to stay as up on some of those things to keep those people close to home. As you guys have mentioned, it's so important to have that healthcare there. So some of the barriers that we're seeing, to give you a little history, we have a couple large plants. One is a turkey plant and one is beef jerky. And so they have brought over the last 12, 15 years a huge diversity to our community. And so we have GRNEN and Burmese, which are an Asian population. These families have flown from their country, or not flown, left their country to go to Thailand as refugees because of war there. Eventually, many of the ones that came to Huron were from Minneapolis. And so they have now come and they're working in these 2 plants. We also have a large population of Hispanic. We have probably 6 or 7 different countries that are working in our area. So that brings a whole new, not only language barrier, but just the cultural differences. Many of the Koreans don't understand preventative healthcare like we grow up with, right? We know we should get mammograms and colonoscopies and do those yearly labs. That is unfamiliar to them because they wouldn't even have healthcare in the refugee camps, obviously. They delivered babies on their own, and out in the jungles, actually. So some of the housing, I'm trying to kind of go over some of those barriers that you guys have talked about. Housing is probably not a huge barrier for us. Probably high end sometimes is. And so that could be a situation, but also the upkeep of their homes. Many of those, again, that aren't used to owning a home, they may have 3 generations in their family. They're just not familiar with the importance of the need to reshingle your home or, keeping the upkeep inside of that. So that can sometimes, I don't know that that's a barrier, but it can be a concern. Huron actually saw a huge need, and our city leaders have added apartment buildings, duplex homes, just some really nice areas for apartment living in place of maybe purchasing that house at the beginning of, their employment or so forth. Some of you have talked about transportation. That is a need everywhere in some ways. Many people can make those appointments out of town if they need to go to a specialist and get there, but many of our Korean and Hispanics struggle with that. They may use their family members if they're understanding how to get there. But we do have people's transit, much as what you guys talked about, that can go out of town during the week and set those appointments up. But then they're 8 to 5. Well, they leave early in the morning, but they want to be back at a decent time. So those appointments all have to work around that. And so we had a grant. I'm kind of going sideways here, but there's a reason to that. we had a grant about 3 years ago for community health workers. I don't know if you guys are familiar with that, but it was an opportunity for us to have, we now have a Korean speaking, Spanish speaking, and then a Caucasian English speaking 3 community liaisons or community health workers. And they have been huge for helping us bridge that gap. The sole purpose is to get into these communities, these homes, and help them make those arrangements. So talking about transportation, maybe there's a child that needs to go see a specialty for a dentist even, or a specialty in a healthcare setting. Our liaisons go into the home. They may go into the clinic appointment, so they hear what the provider is needing and advising them to do. They make sure and remind them of those appointments so they get there, because sometimes they don't realize the importance of getting down there. And so those liaisons here at HRMC have been a huge asset to our communities to help with that type of thing. We also have helped them with medication assistance financially. And sometimes we have our church members reach out and may take somebody down there too for appointments and so forth. So we've had as creative as we can be to help support those people. Mental health services, we have a community, CCS, community counseling services. They're throughout the South Dakota. But recently, the last 2 or 3 years, we have actually had 2 individuals start a business for counseling. So that has been great asset for our children, just some specialty areas there too. So that has improved. Luckily, and many of them are from this area and they've come back to work in this area. So that's nice. Along with that, we promote, we kind of grow our own. I think that was a conversation that Brock had last week, whatever that was, about growing that. And we have really focused, and that's really what my role is all about, is focusing on students and helping them maybe come back and work into our area in any of the healthcare needs. But I tell you what, we're expanding it out into manufacturing and everything. So supporting our students that are from this area. One thing about our Korean population especially, this is their home. And that is huge because we have been able to get Korean and Spanish speaking employees here at HRMC. And it's just such a plus to be able to support those patients when they come in and have somebody familiar and in person interpreting for them. And maybe they're a nurse. We've got a couple LPNs, a couple RNs. And so that is huge when it comes to delivering that great healthcare. So insurance wise, I shouldn't say most, I'm not the one to know like percentage wise how many have insurance and so forth. But I would say like one of our plants, we did a health screening. HRMC did a health screening fair out there this year. And they're probably about at 85%. And they were still talking to those that didn't have insurance, encouraging them to get that so they can do that preventative care. And there's some coverage there for them. So I was going to say about promoting our own. One of our general surgeons and one of our orthopedic surgeons both grew up in this area. And it took a long time. Schooling takes a few years, but they ended up coming back and now they're raising their families here in Huron. So that's huge. We also obviously help them with scholarships. We are Build Dakota to bring them back. But we also support the BSN nursing degrees, physical therapists, CRNAs we've helped. And then, of course, we have either the scholarships or sign-on bonuses, and we have nice packages for our CRNAs and medical students if they're coming back to work into this area, whether it's moving fees, stipends during their residency, and so forth. So we are doing everything that everybody else is trying to do out there to help promote and be able to have that rural care that everybody deserves out in the rural area. I have to just elaborate on yourselves because so many of you talked about relationships, and it is so true. You become a family and you support each other, whether it's work or it's outside of work and tragedy has happened or something, they come together and support each other so much. But you also gain so many skills in the role, or maybe maintain your skills, because we don't have an IV team and we don't have a code team. It is all of you as that are responding. If we have a trauma that's called from out at a scene, there's a trauma team. It's called overhead. Somebody from every department, whether it's nursing, comes and responds to that, and you maintain those skills that you might not in a big setting. So I encourage you to all consider that. I know somebody mentioned they have the 3-year commitment. That's great. You can get some experiences, but it is, in one of my other roles, I was a director, and I can say I've hired many young families that wanted to come back to the rural area and raise their families. So keep us in mind always. What kind of I kind of felt like I went through that really fast, but I know we're short on time. Are there any questions that I can help answer?
I thought you did a beautiful job on that. Not only talking about all the the different barriers and stuff you see, just such a unique population there, and with the plants and everything, I think it was just perfect. And then you did such a good job talking about trying to grow your own. Here, I agree with you 100%. Huron that community in that hospital has done some wonderful, wonderful things. So I do hope some people will consider going to Huron community, if not right out of school, then after your couple years somewhere else, because I think it'd be a great place to raise a family and a great place to work.
Yes, it is.
One question I had for you, those community, what are they called, community health workers?
Yes.
Since that was grant funded, then is the grant done, or like who pays for them now?
Yes, it is completed. It was about a year ago it was done. We actually can charge Medicaid reimburses for their services. Medicare can. We are submitting it to insurances, and some insurances are covering it, some are not. So we have to be very upfront with those that are in need, that we will submit it. We will do everything possible to get this covered for you, but it will depend on your policy that you have. There is a lot of push through the state people that develop the CHW program to get everybody approving it. It's so beneficial. I mean, it has been really a wonderful asset, and they do a wonderful job. And it's just that trust they don't understand sometimes, especially when, English is a second language.
Right. The relationship piece again. They build a relationship with them, and so they trust them, and they're more apt to listen to what they recommend.
That's right. That's very right.
Yeah, excellent. Well, I'm glad they still have them, even though the grant is done, and they're able to at least hopefully continue. I seem like the reservations, a lot of them have like community health.
They have CHRs, and that's where the CHWs, community health representatives, they have had them for 50, 60 years, and that's where this spun off of.
Okay, perfect. Yeah, and I know they're really valuable there too. So, questions from anybody on any of this, from any of the speakers? What things are you curious about? Anybody? I guess the one other thing, I know we're almost out of time, that I noticed some of you talked about that you have assisted livings or like nursing homes attached. And I know there's a huge shortage of those in South Dakota. So I would be curious, for those of you who have them, are they usually full? And like, do you have waiting lists, or in the communities that you're in, that you have them? Any of you who saw them?
I know the one in Freeman was really full, and like there's always people trying to get into it. I didn't mention that we had one, but we do have one, and I know that it's full.
That's true. Okay. Awesome. Thank you.
The one in Viborg also was always full. And then the dementia and Alzheimer's unit that they have too, that was kind of like a big thing. There was always a long list and waiting list for that.
Yeah. That's sad, isn't it? That some of these poor people who really need this help can't get it. So, okay. All right. Any other thoughts, questions for anybody today? Okay. Well, I want to thank you, and I'm going to turn it over to Stacy for final comments, but thank you so much for being with us. And Stacy, it's all yours.
There we go. No, thank you to all of the presenters. This was a really great and powerful presentation as always. I just dropped into the chat the Echo feedback link. This is going to take you to a quick survey. It's pretty short, but we always say how the feedback really does go a long way as we build future programming. So if you would take 2 minutes of your time and just kind of click on that and fill it out for us, we'd be really grateful. Well, thank you everyone again for taking the time to visit today. We will be posting the archived recording on the grnen.org website. All of the Heart of Rural Nursing on-demand webinars can be found there. So if you liked what you saw today, please feel free to look at a session or share one with somebody who might not have been able to join us. And we look forward to seeing you at the next event. Take care, everyone.
Bye.